Hello, everyone. I think we're going to go ahead and get started. Welcome to Mini Med School. This is our fourth session for this year. We're very excited to have you. It's my pleasure to introduce our first speaker, who is Madison Calvert. She is a second year in the MD-PhD program here at UNC. She graduated from Boston University in 2021 with a BS in human physiology. And after graduating, she spent 2 years as a research fellow at the NIH, where she studied pediatric reproductive endocrinology. This fall, she will be starting her PhD in the Gillings School of Public Health's Epidemiology Department and plans to focus on reproductive and perinatal health with a focus on improving labor outcomes in global settings. Outside of school, you can find her at the Yoga 6 in Meadowmont teaching hot yoga or at the park with her chocolate lab singing. So without further ado, please welcome Madison.
Hey, good afternoon, everyone. Welcome to Mini Med School. I'm excited to give a little chat today. And so today I'm going to be talking about OB-GYN throughout the life stages, menstruation, pregnancy, and menopause. And then Dr. Darivemula will come after me and kind of elaborate a little bit more. So I'm excited to give this warm-up talk. And yeah. Okay, so the first thing I kind of wanted to go over is reproductive anatomy. And so just to give you a general overview, we have in the center our uterus, and this is kind of where everything happens. At the end of our uterus is what is called the cervix, and this is the opening to the uterus. And then from there is the vagina, which connects to the external part of the body. Coming off of the lateral or sides of the uterus are the fallopian tubes, and these are the connections or kind of like tunnels to our ovaries. From our ovaries, we produce our eggs, we produce our hormones, which I'm going to talk about in a little bit later. And like a fun fact that I like about the ovaries is that they're actually kind of like floating in space almost. And these little fimbriae at the end of the fallopian tubes is what kind of connects them and grabs onto the egg as it releases from the ovary. So, what are hormones? We talk about hormones a lot, and sometimes it's very ambiguous. I don't know what a hormone is. I know it's estrogen, I know it's progesterone. So, we're going to talk a little bit about what these are and what they do in our body. Okay, so if you look closely, we have this pathway in our body. It's called the hypothalamic pituitary axis. And it starts up here all the way in the brain. And so in the brain, we have a structure called the hypothalamus. The hypothalamus produces what's called GnRH. And this is a stimulating hormone that then acts on the anterior pituitary, which is another brain structure, to release two things that are called gonadotropins. These gonadotropins are known as FSH and LH. So our follicle stimulating hormone and our luteinizing hormone. These two gonadotropins then work in pair to act on endocrine targets. Our endocrine targets specifically are in males, testes, and in women, ovaries. These ovaries, which I'm going to focus on today primarily, are going to produce estrogen and progesterone, which is largely what we talk about when we talk about the female reproductive hormones. But just kind of for reference, we still do have these kind of more upstream hormones that are also acting in play with our bodies as we develop over a course of a month, but also over the course of our lifetime. And then the fun fact is also that estrogen and progesterone don't only work to kind of act on reproductive health, but they also act on many other tissues in this body. And so we're going to talk a little bit about what those actions are. So estrogen primarily is involved in the development of mammary gland tissue during puberty and also during pregnancy. So the development of your breasts. It also helps with the proliferation of the endometrial cells in preparation for pregnancy. These endometrial cells are going to be those cells that are lining the very inside of the uterus, which I showed earlier. And then the estrogen is also helping to support that epithelial mucosa and the cells of the vagina and the vulva, so keeping the skin and the cells healthy and nourished. It's also going to help in the development and protection of bones. So this is often seen in puberty as children are growing and the fusion of the growth plates. But then also this comes in role, which we'll talk about later during menopause as you age and you start to lose progesterone and you lose that protection of your bones. And then lastly, it also increases healthy cholesterols or the HDL levels in the body, which ultimately reduces risk of heart disease. So estrogen is playing a role not only on our reproductive organs, but then also all over our body to really help through development and growth and just maintaining our overall health. Progesterone is what's known as the pregnancy hormone. So progesterone primarily is involved in preparing the endometrium, that inner lining, for gestation or for pregnancy and carrying a baby, and maintaining a healthy pregnancy. This helps to increase the capillary growth and the vascularization of the uterus, so bringing blood vessels in and helping to keep the space nourished. And then also increasing mucus secretion and creating a protective barrier in the uterus. So throughout lifetime and our lifespan, these hormone levels change. This happens both on a monthly occurrence with our menstrual cycles, but then this also happens as we age, through puberty, adulthood, as we become pregnant, and then as we go through menopause. So I really like this picture because it kind of shows you these estrogen levels. You can see in your 20s and your 30s, you have a pretty high amount of estrogen in the body, and it peaks at about 35. And then as you start to age past 35, your estrogen levels start to go down. And this is just a natural process that happens, similarly as it's natural for our hormones to go up and down during our menstrual cycle. And so kind of today's talk is focused around like, what are these changes that are happening in our body as these changes in our hormones are happening. So the first big change that happens with your hormones is going to be your menstrual cycle. And so this is a very complicated picture that I think even scares medical students when they see it. So I'm going to try and walk through it pretty briefly and just breaking it down. And so again, we have those two main hormones, estrogen and progesterone, and we have 3 different cycles of our overall menstrual cycle. The first being menstruation or menses, which is what is more known as your period. And so that's your active bleeding phase. And then we have our follicular phase, ovulation, and then our luteal phase. So I'm going to start with the follicular phase. This is the phase that is controlled predominantly by a rise in estrogen. This happens to mature our follicles in the ovary. And so at the very bottom of the screen, you can kind of see these little circles, which are our follicles, and they start to grow over the course of your follicular phase. They grow to develop a dominant follicle, and this happens under the influence of FSH, which is stimulating these follicles to produce estrogen. And then about halfway through our cycle at day 14, what happens is known as ovulation. And so ovulation is triggered by that steep rise in estrogen, which is that blue curve going up. And that blue curve going up then makes LH peak. So that's that big red peak in the middle. This LH surge is really what defines ovulation. And what happens is it causes the release of the oocyte or the egg from the dominant mature follicle. From that point, then we enter what's known as the luteal phase. And so the luteal phase is all about progesterone, or that pregnancy hormone. And so this phase is about preparing for pregnancy. And so that ruptured follicle right here ends up turning into what's known as this corpus luteum. And it's a structure that is helping to prepare the body for pregnancy, producing this progesterone. And if you were to become pregnant, then this would stay high, and your corpus luteum would remain. If a oocyte is not fertilized and implants, then this corpus luteum degenerates and your progesterone levels go down. And then this really steep drop in both the progesterone levels and the estrogen levels is going to cause menstruation or your period. And so then you're back here at the very beginning. And the period is ultimately that shedding of the endometrial lining. And so this is just a picture of what's going on in the actual endometrium of your uterus, or that inner lining. And so you can see over the course of the follicular phase, it's slowly just growing in size and in thickness. And then once you pass ovulation and are in that luteal phase, you can see it gets a lot thicker. There's a lot more capillaries and blood vessels, and they start to form a different architecture as well. And again, this is just preparing the body for pregnancy. When those hormone levels decline, then you get the shedding of that, and you end up all the way back at the beginning. And so this is something that's happening every single month in a woman's body. So I think OB-GYNs like to think of bleeding as a vital sign. And so when we think of vital signs, we think typically of your temperature, your blood pressure, kind how fast you're breathing, how fast your heart is beating. And these are things that in medicine, we typically immediately, it's like, what are the vital signs? How is someone doing? Are they sick? Are they not sick? And so bleeding actually really should be considered a vital sign because it can be used to predict health outcomes, indicate necessary treatment, and also monitor clinical status. It can change from menarche or the start of your period through menopause, and it reflects overall women's health. Menstrual irregularities specifically can also indicate hormonal imbalances, gynecologic diseases, or infections. A menstrual cycle typically ranges from 24 to 38 days, and a normal period typically lasts less than 8 days. And so anything outside of that range is what we would call an irregularity. Abnormal uterine bleeding specifically is a very broad term that OB-GYNs like to use that describes irregularities in the menstrual cycle, and it typically involves changes in frequency, regularity, duration, and volume. So next, I kind of want to talk about abnormal uterine bleeding at different stages of life and different things that can cause it. So when you're an adolescent, right after starting your period, it's very common to have an abnormal period and abnormal bleeding cycles. And so that's the first cause of abnormal bleeding would be immaturity of the HPO axis. So that's that cascade of hormones that I was talking about earlier. As you're developing and when you're young, sometimes this takes a little bit for the body to kind of get that signal and say, okay, this is what's happening. And so until that matures, it's often that young girls don't have a very regular period. Other changes that can cause abnormal uterine bleeding in adolescents are PCOS, thyroid dysfunction, mental stress, eating disorders or excessive exercise, coagulopathies or blood disorders, malignancy, and sexually transmitted infections. Menstrual abnormalities within this kind of time frame that may require evaluation are typically ones where you're starting your period later on, or if it's occurring really frequently or less frequently. In adulthood, we try to think of abnormal uterine bleeding in these like 9 different topics. So we have structural on the top and non-structural on the bottom. This is called our POM coin acronym. So structural causes of bleeding are polyps or outgrowths of tissue. These can be asymptomatic. Most of the time they are benign. Adenomyosis, this is the presence of endometrial tissue within the actual uterine muscle, and it can result in very heavy, painful bleeding. Fibroids, these are benign smooth muscle tumors that can lead to heavy and very prolonged bleeding. And then another structural cause is malignancy or hyperplasia. This can be caused by prolonged estrogen exposure and can lead to unpredictable bleeding. And then some of the non-structural causes that we look at are coagulopathies or those blood disorders, ovulatory dysfunction, so that includes PCOS, thyroid, and then endometrial and iatrogenic causes. And then we also have just a bucket for just things that don't fit into any of these categories. Okay, and then we also look at bleeding during pregnancy. And so vaginal bleeding during pregnancy can cause by many things, and it often is a common thing in early pregnancy. About 15 to 25 out of every 100 pregnancies in the first trimester will have some sort of bleeding. But bleeding later in pregnancy can be more serious. So different causes of bleeding during pregnancy can be infections, early pregnancy loss or miscarriages, ectopic pregnancies or pregnancies that are located not within the uterus, but usually in the fallopian tubes, placental abruption or detachment of the placenta from the uterine wall, placenta previa, which is when the placenta comes over the opening of the cervix, and then also placenta accreta when the placenta actually attaches inside of the uterine wall. Another cause of bleeding during pregnancy could be preterm labor, and then also uterine rupture. And then kind of to tie out the end of our life course, we have menopause. And so menopause is the permanent end of menstrual cycles due to the cessation of the estrogen and progesterone production from the ovaries. And so kind of how we saw that steep decline in our menstrual cycle, this is similar to what happens during menopause. And so we like to define menopause as a minimum of 12 consecutive months without a period. This is a non-pathologic estrogen deficiency. And more than 80% of women experience menopausal symptoms, but there's also very great variation in personal experiences and what kinds of symptoms that you may experience. So some of these include vasomotor symptoms such as hot flashes, night sweats, palpitations, migraines. You can also have GU symptoms, which would be vaginal dryness, burning, itching, irritation, urinary frequency and urgency. Psychogenic symptoms such as anger, irritability, anxiety, depression, loss of concentration, loss of confidence, sleep changes, decreases in sexual function, and like I mentioned earlier, a bone mineral density loss from that loss of estrogen. And so my last question that I want to address is, what is the role of an OB-GYN throughout the life course? So I think often a lot of times OB-GYNs are looked at and thought as of something that you only go to when you have a problem related to your period, or you're a reproductive question, or you're pregnant or looking to have a baby. But it's also important to look at the role of an OB-GYN at every stage in the woman's life, from puberty through pregnancy, menopause, and beyond. OB-GYNs are here to support their overall health needs and often can catch other things and be an opportunity to decrease chances of developing chronic medical diseases, especially in pregnancy. You go through so many different screenings, catching things like diabetes or hypertension, and being able to kind of support you through that and provide a place where you're receiving continuity of care. So these are my references, and I think that is all that I have for you guys today. Thank you for listening. We're going to take about a 5 to 10 minute break, and then we will have the next speaker come up.
Back. Great. Finally. Hi, guys. My name is Shilpa, Dr. Darivemula. I'm one of the OBGYNs at UNC. I am a menstrual equity researcher. I do a lot of work around menstrual equity needs, looking at people in different vulnerable situations and what their access to supplies looks like. I also look at counseling in the clinical setting and seeing how we actually talk about this topic as OBGYNs, if we do it at all. And so currently pursuing a master's in clinical research through Gillings with the goal of being an academic clinician. So this talk, I think, Madison did a beautiful job talking about the physiology of bleeding. And when I got the prompt to do this talk, it was very broad, like hormones across the lifespan. And I think for an OBGYN, like I could go down every single possible detail of it. So I got a little lost initially putting the PowerPoint together. So what you'll see is actually just me thinking of all the things I wish I knew before I became an OBGYN, when I was a patient, what I wish my mom knew when she's a patient. And I kind of hope that by hitting a bunch of topics really randomly, I would say, throughout this conversation, I hope that you guys will just raise your hand, ask questions as we go along. If you have any thoughts or experiences you want to share, please do. This is a very open, interactive forum. We have the hour, so we'll use the hour. Okay? So just please raise your hand as you have a thought or question that you want to ask. And forgive me for being a little all over the place. All right, so disclaimer and disclosures. So we acknowledge, first of all, that all individuals who menstruate do not identify as women, and that not all women menstruate. And so we recognize that that is a truth. However, the research and literature and clinical work that we do does not reflect that reality. So a lot of the words you'll see actually come out of what the literature shares, which is women, pregnant, mother, and we recognize that those are not the terms that everyone uses. So I apologize in advance, and I hope that you guys will forgive me for that. No, I have no financial disclosure to share. So group question. I'm going to ask y'all a question. What is the menstrual cycle and why does it matter for health? What do y'all think? You got a little bit of the menstrual cycle answer already. Yeah, go ahead. Yeah, absolutely. Anybody else? Why do we care? Just bleeding. Yeah. Yes, it's true. Very true. One more person, then I'll let y'all go from the silence. Yes, that's so true. That is very true. We'll get into that as well. It's a great point. Thank you. As an OBGYN and as a person who menstruates, I think it completely matters for your life. So I'm not going to go back into all the details that Madison went through beautifully. But basically, the menstrual cycle is a monthly process of preparing the body for potential pregnancy, right? Like if you distill down the point of the cycle, that is essentially the cycle. You're essentially training your body every month to prepare for pregnancy. You exercise the body and then you like let it go. Exercise, let it go. And then whenever you decide to get pregnant, that's when you get pregnant. And so this is actually just cyclical training for that, the cyclical readiness for that, and then getting your hormonal signals kind of through practice and repetition more organized to sync up and set up a cycle that you can rely on. Ovaries make the most of estrogen hormones, but actually your adrenal glands, which are little triangular glands sitting on your kidneys, and fat cells in the body. So anywhere there's fat cells, there is estrogen being produced. Those are other two sources of estrogen production in the body. So just so you know, it's not all just your ovaries. And so this is just the review of exactly what Madison said, but basically there's this pulsatile signal from the pituitary gland that kind of starts signaling around the time of like 10 to 13 years old. It starts kind of rhythmically kind of signaling over and over again. And finally, FSH at a certain point will say, I hear you, GnRH, and will start sending signals to the ovaries. And that grows a dominant follicle, right? A bunch of little follicles grow and only one ends up the winner, the chosen one for that month. And then that one shoots out an ovary. So basically your ovary has a little eruption every month. It actually just like bursts through the cells and shoots that egg out into space. The fallopian tube is hanging here. The ampulla and the fimbria are like sitting there like a little jellyfish octopus, just looking around for that egg, collect the egg, and then it starts putting it down the tube. And so if you have intercourse at the right time, then sperm will somehow fight the fight all the way up your cervix. The battle, millions start, and there's like only one that survives. And they kind of go through the cervix, they die a lot there. They go through the uterus, more die there. And then finally, when they can make it to the final little fallopian tube at the top of the uterus, they go through, and if they meet in the tube, that is where you get pregnant. So most pregnancies start in your fallopian tube. And in 6 days, it rolls and rolls and rolls and develops into 16 cells called a blastocyst, and that lands on the endometrium. And that's how pregnancy starts. So if that doesn't happen, that egg just sits there in the tube, rolls around a bit, and then suddenly it's like, no one's coming, done. And so it dissolves. And in that point, the endometrium that's been growing fluffier and fluffier and fluffier over the past month, waiting for something to land, says, oh, nothing's happening? Okay. So then it sheds. And that's kind of how the menstrual cycle goes every month. Go ahead. That's a great question. You know, no one has ever asked that question. I've never seen that in any kind of book. Oh, sorry. The question is, I'm about to eat that. The question is, do the ovaries take turns sending out an egg? I actually don't know the answer to that. I think that that is not something that we have looked at. We do know, for example, if you lose a tube, say ectopic pregnancy, we take out your tube, your chances of getting pregnant are still the same as somebody who has 2 tubes. Maybe slightly reduced, but not enough to be like, you're not going to get pregnant, you know, at the same rate. So somehow, I think, because remember, the way the ovaries, it's not this. It's actually sitting like this. It's like, this is the ovary. The tubes are like backwards like this. The ovaries are like right next to the tube, like in your where your vagina is, like in the back, in your rectum. They're sitting on either side of your like colon. So they're all kind of like flung backwards like this. And they basically, like, the egg can shoot, and there's tubes sitting there ready to catch it from both ends. So we actually don't know which one shoots the egg. Just letting you know. Yeah, great. I hope you guys like that dance demonstration. All right. Estrogen, right? Like it grows, it does 2 things, right? This is like a 2-phase part. So ovaries is one phase. There's 2 phase names. One is follicular phase, which is growth, ovulation, and then the luteal phase. And then the estrogen also has the impact on the endometrium, which is the proliferative phase, which is the growing phase, like follicular phase of the ovary. And then the secretory phase, which is the shedding phase. So the estrogen is doing two things in two different organs, and they're coordinated together to kind of sync up for pregnancy. Yeah. Could be. Yeah, could be. It's actually, these are such great, I actually don't know like if we've ever looked at which ovary shoots the egg out, because it's so hard to capture. Because these eggs are so microscopic, it is really hard to, unless you have some incredible nanoscopic microscope that we can look into the abdomen and see, we will actually never know which ovary shot out the egg. The way we do know that the ovary, like at the afterward, the ovary shot off an egg, is that on the same ovary, a corpus luteum forms. So if you get pregnant, the thing that keeps the pregnancy alive is the shelled out egg. That egg space in the ovary that shot it out turns into corpus luteum, and that gives you progesterone hormones so that you don't ever have a cycle. So as your placenta develops, that takes about, I don't know, 4 to 5 weeks for the placenta to grow. The corpus luteum from the ovary that shot out the egg, that would protect your pregnancy, give you progesterone, and then when your placenta grows large enough, that takes over to maintain the pregnancy. So it's actually, maybe that, if you wanted to look at it that way, where the corpus luteum is probably where the egg came out of. When you have twins, usually do not have two corpus luteum. So I guess if I had to think backwards, probably just only one ovary shooting out both eggs. Great question. Any other questions? Yeah. Sure. Yeah. That's such a complicated question. So that depends on your age, your health, your partner. Yeah, those would be some like major factors. So I can't give a number off the bat, but most people, if they're less than 35 years old, about like 82% get pregnant within 12 months. So we don't look at like each time, like it's a lot like scale. It's not about, during this time of intercourse, will I get pregnant? It's more about across time, what is my chance of getting pregnant? And in 12 months, 82% for somebody who's less than 35 years old. After 35 years old, that drops to probably like 76, 70%, which is why if you don't get pregnant in 6 months after 35 years of age, we recommend you see a doctor. You can try up for a year before then. Yeah. Oh my gosh. I love this. Yeah. So, no, it's a great question. I'm just trying to figure out how to word it correctly. Okay, so once you go to age 38, while we are still physically young, our ovaries are not. And so the quality of eggs and the ability to get pregnant drops tremendously starting at age 38. So you'll see like all these like fecundity, ability to get pregnant, which is fecundity graphs. You'll see that at 38, the quality and quantity of eggs drops pretty quickly. By 40, 41, it's pretty low. And so starting at 38, sometimes the ovary does not function as it usually would. And in the eggs that are existing, they are not of the highest quality. So when a pregnancy happens, and there's a twin pregnancy at age 38 to 40, it's usually not a fraternal twin. It's usually an egg that divides very early because it's a little bit more jumpy, or it's not as stabilized as eggs in previous ages would have been. Does that make sense? So it's kind of like a unique creative experience. The egg just decides to split, and it splits more easily because it's not as stable. Yeah, I'm trying to say it in a way that's not what I've learned in medical school. So yeah. Any other questions? Cool. All right, so mental health impact. We talked about this really quickly too. The estrogen closes the epiphyseal growth plate in bones. So for those of us that got our period really early, like 10 years old, you might find that your growth curve is pretty limited. You don't get to grow as tall. And those of us that had periods really late in life, like at 15 or 16, you might notice that we're pretty tall. And so That's because the estrogen that you have in your body, that actually closes that final growth plate, that physical growth plate in your long bones. And so if you have it really young, you actually end up being a little shorter than you could have been. Your growth potential is severely reduced. And if you have it much later, you keep growing and growing because you never get that estrogen closure of the growth plate. And so you end up being a very tall female or menstruator. So that is something of interest. Loss of estrogen actually increases osteoclasts, which are the modulators that actually eat bone. And it increases the activity of them when you're older. So when you go through menopause, you'll notice people have an increased risk of osteoporosis. That's because these osteoclasts without estrogen are not controlled anymore. They go on a wild rampage and start to chew away bone. So that's what we say when you're younger, you want to do weight-bearing exercises till you're age 30, because when you're 30 is kind of when your bones develop the maximum mass they can develop. And after that, it's just a matter of losing bone over your lifetime. So if you're less than 30 in this room, hit the gym, lift those weights. It's the weightlifting that's going to give you good bones and prevent osteoporosis, especially for my Asian friends, because we have an increased risk of osteoporosis and bone loss pretty early. All right. Estrogen is protective against depression and cognitive decline. So yes, how this works, nobody knows. So I know people always make these comments about PMS and perimenopausal mood changes. I always kind of find it a little bit hard to deal with because it's like, is it really the estrogen or is it the fact that I'm bleeding and I'm uncomfortable and I'm annoyed because I'm bleeding, right? Like, or I'm annoyed that you're saying PMS in my face. Like, I don't really understand that part of it, but I do know that data shows that there's an increased risk of Alzheimer's if you have early menopause. So if you're less than 40 and you have menopause, that is called premature ovarian insufficiency. And we get worried about that because your risk of osteoporosis, heart disease, lung disease, and heart disease, colon disease, and Alzheimer's increases. So, and excess estrogen is also not great, right? It can cause breast cancer, uterine cancer, and interestingly, estrogen also protects against colon cancer. So the balance, right? You're talking about balance. You really want the system balanced because that is how you're going to get the maximum time in your life with good health. So I don't know if anybody's heard about this whole conversation around hormones are bad for you. Postmenopausal hormones, HRT. Did anybody get that talk ever that don't take HRT because you can die early? Raise your hands. Anyone's heard that conversation? Great. This is the culprit study. So this is Women's Health Initiative. It was actually done in 1991. They did a 15-year study looking at about 161,808, I can never say those numbers, women aged 50 to 79 across 40 clinics in the United States. And they basically divided them up into 3 different categories. People that got estrogen, progesterone, people that got estrogen alone, and people that got a placebo. And they actually had to stop all 3 arms of this trial pretty early because they all had adverse effects. Now, what they did not do is that they did not offer transdermal hormone therapy. They offered the pill version, which is actually the one that has the highest risk of all of these concerns like heart disease, strokes, DVTs in the legs and lungs, is when you take the pill version. But if you take the patch version that goes through the skin, avoids the liver, right? Because it doesn't have to go through the GI system and get processed, you reduce all those risks tremendously. Plus, they gave these treatments to people that were 79 years old who didn't have hormones for like 30 years and then gave them hormones and said, are you doing okay? And they were not. And so when they went back and looked at the study later, they actually divided it up between 50 to 65 and then 65 to 79. And they found out all of these problems that happened in the study were because were mainly in the group that was older, not the group that was younger. And so when I was in training, we did not study HRT. I never got the lecture. No one ever taught me. They were like, don't give it, don't do it. People are dying, which is unfortunate because now we have a whole group of women, group of menstruators, people that have uteruses that are not getting HRT and are experiencing advanced chronic, cognitive decline, going through vasomotor symptoms, suffering really intensely, and not receiving the benefits of it because people have been so scared to give it. So now we're kind of tracking back, taking a step back. I don't know if you saw Halle Berry on the latest talk. She's been talking a lot about HRT. There's a lot of push to talk about HRT now. So I'd strongly recommend all of you folks that are between 40 to 65, you've just gone through menopause recently, to go talk to your doctor about HRT. Say like, I would like to try it, just the patch version, because it can really improve your life and your living style. It can decrease your risk of bone loss, bone breaks, colorectal cancer, heart disease, and expand your life as well. So just ask them, because I think this study kind of set us back. And to that point, HRT, there's a recent study that came out of Israel that looked at people with colon cancer and compared those that had HRT and did not, and said that HRT did protect them against getting colon cancer. This study is a little bit odd because they use oral pills and not the patch pills, so I can't quite tell how that would translate to our people here. Plus, it was a retrospective study, so they like looked at people that got colon cancer and then said, oh, you got HRT, so there must be an association, which, as we all know, is not the best way to test out data. So plus or minus on that study, but they say it helps. This study is actually really cool. So this study just came out of Mass General. It's the Apples Women's Health Study. So now we talk a lot about, menopause and postmenopause, but actually regular cycles are really important when you're young. So those of us that have PCOS, that have irregular cycles, that have abnormal weight gain when we're younger, it's actually really important to get those cycles under control. Like, you shouldn't ignore it. You shouldn't be like, it's normal to bleed this heavily, or it's normal to not get my period 3 months in a row, because actually that has been now shown to increase your risk of the same things that people with perimenopause experience. So heart disease, you can get an increased risk of hypertension and stroke and diabetes if you do not regulate your PCOS, if you do not get regular cycles. So having irregular cycles for a long period of time as a young person can actually set you up for earlier experiences of cardiovascular metabolic disease. So yeah, go ahead. Yeah. So when you use contraceptions, when it's iatrogenic, right, we've induced a cycle of no periods. It's actually protective in many ways. So remember, when you give a hormone therapy, you're actually stabilizing the hormone levels. So there's no ups and downs. The importance of menstruation is not about having hormones going up and down every month. It's really about regulating and controlling endometrial growth and controlling ovarian function. So that when you put an IUD in, you actually stabilize the hormonal level. So you get the stable amount of estrogen and progesterone throughout. You are controlling the endometrial growth. So you're not having excessive growth. So you reduce your risk of having irregular bleeding, abnormal bleeding, or pre-malignancy. And then you also prevent, in IUD, the ovary still ovulates. If you take the pills, for example, there's no ovulation. So you've actually prevented your risk of ovarian cancer in the future. So we actually tell people, if you take birth control pills, you actually prevent, I told you every month your ovary kind of busts out an egg and it's like a little explosion. Well, years and years and years of explosions on your ovaries can actually increase your risk of cancer. So again, just to remind everybody, ovarian cancer incidence is very low. It's like spontaneous, and people that don't have a history of it, it's like 0.6%. It's so low. But if you're somebody that wants to prevent that risk, one way to do it is through birth control. You stop the ovary from shooting out an egg every month, you stabilize it, it doesn't have that risk. So it can help out. I would argue depends on what your issue is. So I would say in somebody who's having irregular cycles, they're young, I would say the IUD is really nice because it just, normalizes your cycles. If you're like 35 and older and you're just having, you want to control your bleeding, you don't have any contraindications to estrogen, I'd say maybe the pills might be better because it kind of gives you a little bit of time away. If you've never had children before, you've never had a break from your cycle, I might say OCPs. If you're somebody that has kids already, I'd say IUD. So it all kind of depends on your context, which how your doctor's going to be your best friend. Yeah, go ahead. Yeah, totally. Mm-hmm. I'm sorry. Yeah.
But she was like surprisingly very young. And she found out it was I was wondering if I know it's
That's a great question. Breast cancer is a whole different beast. I'm sorry about your mom. But I will say that when people, so I know the aftermath of this. When you get breast cancer and you come see an OBGYN, what they usually recommend is they put you on some sort of estrogen inhibitor, right? An aromatase inhibitor, which is the enzyme that creates estrogen in your body. Or they'll put a different type of inhibitor, which like a SERM or something like tamoxifen. They'll put you on that for 5 years to prevent breast cancer regrowth. Recent studies through the ACOG, which is our guiding institution, have said that actually, if they don't have estrogen receptive breast cancer, so estrogen ER/PR positive breast cancer, if they have triple negative breast cancer, you can actually give them hormonal therapies safely because that will reduce their risk of recurrence. If they have ER/PR positive cancer, then we say we prefer not to give them hormones, and that we would, let them kind of manage going forward as they wish. If they needed any kind of like topical hormones, that's okay. Like vaginal estrogen's okay, but no hormonal therapies. I have no idea if exposure before increases your risk. What I will say is if you have hormones before, you're probably regulating your cycle, which means you're having the ups and downs of estrogen, which means you probably are reducing your risk of breast cancer because you are not having perennial exposure because of irregular cycles at high levels. Does that make sense? Yeah, okay. Yes, you are correct. Yes, they do. Absolutely. All right, yeah. Yeah. Right. The differences? Yeah. So who's a candidate for what? Yes. So there's two types of OCPs. There's there's combined, estrogen, progesterone combined, and there's progesterone only. Progesterone only, you take it every single day at the same time, small microdose of progesterone, and it prevents pregnancy for 24 hours. If you miss the 3-hour window to take it, you're exposed to pregnancy. It's not everyone's favorite, but if you're just post-delivery, for example, we might send you home with that because it's just you take it every single day and you are protected till you decide on what you want to do next. We can give you estrogen for like 6 weeks after delivery. The OCPs have two different forms. There's monophasic and triphasic. There was a whole period of time when OB/GYNs were trying to like mimic the cycle, like some like voodoo kind of stuff, where we're like, oh, let's just like increase it, like we're mimicking the cycle. But it actually didn't pan out that way, and it's not very useful. So we actually don't use the triphasic anymore. We only use monophasic, which is the same dose every single day because it works. So we stopped with the whole copy the cycle nonsense. Cool. All right. Yeah, menstrual cycle over the time. Basically, estrogen kind of goes up and down over your lifetime, which I think we've all kind of figured out already. You can see here's what I think is really cool about this picture is that puberty and perimenopause are pretty much the same. Like you realize that like it's like you're starting up slowly and then you get to a good like steady state and then you're kind of slowing down the same way. And I think we just forget when we're perimenopausal that we already went through this when we were kids, where it was just like irregular, you bleed randomly and you go to the bathroom, you're like, what? It's like the whole thing, but just backwards. And then basically post-menopause. So this is just some data on like normal menstrual cycles in adolescent girls. I would say that if you see breast budding in your child, then about 2 to 3 years, expect a period to happen. 90% of cycles are within 21 to 45 days of range. Because remember, the cycle is just starting up. You have that first picture, right? It's going to mess up a few times. It's figuring itself out. So it takes about 3 years to get a regular cycle after you get your first period. So like if you're like, when I was a kid, I remember like drawing in my agenda, like I got my parents very excited. And then I was like, every month on the 1st, it's going to happen. And of course, some kid was like, is that a period? And I was like, oh. But like I like wrote it in my journal and I would get pissed off when I would be like early or late. And I didn't understand why I didn't follow the rules, but it takes 3 years. Got to give yourself some grace. So in adolescence, these are the kind of signs and symptoms you should look for when you're concerned about your period, right? You don't get your period after 3 years of having breast budding. You're 14 years old and you have signs of like male pattern facial hair growth. You have a issue with an eating disorder. You're a high frequency runner, for example, and that story. When you run really hard for a long time, your body's under a lot of stress. And when your body's under stress, your periods are the first thing that goes. So your system will not, put all your energy towards survival. It will not put your energy towards reproduction, right? Because it doesn't make any logical sense for survival. Why would we care about reproduction if we can't live? So when your body is in a high endurance state, starvation, stress, hard workouts, your system will shut down. You will not get a period. And that's just to keep you alive. The rest of the symptoms you can also read. The one thing I do want to highlight is like the number one reason for adolescents to have an abnormal bleeding disorder is they have an abnormal bleeding cycle is because they have a bleeding disorder. So von Willebrand's disease is actually a genetic condition that's very common amongst a lot of folks. And if you have heavy bleeding, you have heavy bruising, you have nosebleeds, you had a postpartum hemorrhage, you might have this condition. So just always talk to your doctor about abnormal bleeding, especially heavy bleeding, especially when you're younger. So this is exactly what Madison already talked about. I'm not going to go through that again. Basically, this abnormal bleeding is actually very expensive for the healthcare system. People lose about $2,000 per year through like work absences and home management costs because they have abnormal bleeding. Fibroids are actually very common. It's a benign tumor. It's a growth of your smooth muscle tumor in your uterus. It can grow 3 different places: in the uterus, in the wall, or outside the uterus. And about 70% of Caucasian identifying women develop fibroids, and greater than 80% of Black women develop fibroids over their lifetime. Another big cause is endometrial polyps. So that's pretty common as well. Just so you know, if you're postmenopausal with a polyp, there's a 10% risk of having endometrial cancer in that polyp. So that's why if you go to the doctor and you have a polyp on your ultrasound, they recommend removing it because we don't want you to develop cancer in the future. And the way we treat bleeding is with pills, the IUD, or something called a hysteroscopy, where we put a camera scope into your uterus. It's like a submarine. We fill your uterus up with water. We look around on the inside, and then we basically take our little instrument, like a little Pac-Man-like device, and just eat the polyp away or eat the fibroid away, and then basically take the whole system out. So that's how we deal with most of these conditions. And of course, there's always a surgery like a hysterectomy. That's what you'd like to do. And I also skipped a lot of other diagnostic in between and a lot of other treatment options. So please don't go tell your doctors that I recommended everyone get a hysterectomy. That is not what I said. Okay. So bleeding in postpartum. I do want to say about this diagram here. It doesn't quite tell you that this is not just like random across pregnancy. There are bleeding disorders at every trimester, and each thing has its own value. So in early pregnancy, right, for those of us who don't have regular periods, if we get pregnant, we actually probably don't know for 6 weeks, right? You won't know till you miss your period, and then you realize you missed your period, and then you got a test. And so that's around 6 weeks. So knowing your period is pretty important. If you miss a period and you test, you might notice some spotting or some bleeding. That's because the placenta is probably attaching itself to the wall. So remember, the placenta is like a vascular structure. It's the baby's kidneys, lungs, and like cardiovascular system all in one giant pan. And it basically sticks itself to the uterus, and it has to form these like bridged vessels between the uterine wall and the placenta. So it builds and breaks and builds and breaks, and it bleeds from behind that placenta all the way out. So you will have spotting. Now, most of us will be freaking out because we're like, is it a miscarriage? Could be. If that bleeding gets too large and basically pulls the placenta off because it just keeps bleeding, then yes, it becomes a miscarriage. But sometimes it's just normal. It just forms and develops, and then it's gone by your anatomy scan. So that is one cause of bleeding. It could be an ectopic where remember I said the pregnancy happens in the tube? So if it stays in the tube for some reason, because the tube is not functional, it doesn't move, it's an abnormal pregnancy, it can grow in the tube and rupture the tube. If it ruptures the tube, that's an emergency. You can bleed out from just having your tube ruptured, and that's called an ectopic. So having some abnormal bleeding is also concerning because it could be stuck in the tube. If you have bleeding in the second trimester, it could be your placenta is maybe too low, placenta previa, or if it's in the third trimester, you could be in labor, or you could be having a hemorrhage or anything of the above. So it all depends on you, your ultrasound, your baby, and what trimester you're in, where we get concerned or not concerned about bleeding. Does that make sense? Cool. All right, so people are always like, what do I eat to have better menstrual health? Everyone's like food. And I come from a big Indian family, and everything's about like spices and ajwain water and like drink this so you feel better. And I'm like, do I have to? Basically, just have a good diet. I don't care what you drink. I don't care what you eat. Salty, unsalty, like I remember my mom used to tell me that back at home, she would have no salt food for like her period so that they wouldn't get cramps. That's not proven out. Like that's not data driven. So like if you want to eat salty food because you are hungry, that's what your body wants, eat it. Just make sure it's a nicely balanced diet, you know? So also please don't clean your vagina. Is anybody into like, the word is called douching, but like putting anything up the vagina and cleaning it or putting special soaps or special Vagisil, don't do that. Like let the vagina is like the mouth. It's like a giant, beautiful, balanced, like bacterial filled space. And in order for you to have a good diet and a good gut diet, they always say like, let the bacteria in your mouth kind of like live. The same thing in the vagina. You want the bacteria in the vagina to live. So let it do what it does. It's self-cleaning, it's self-fixing. Don't fix it yourself. All right. People ask about exercise. Like when should I exercise? When am I like the most potent for exercising? Right. People, like, I'm sure when you get your period, you're like, I'm not exercising. I'm done. I'm going to lay in bed. This is it. But I will argue that some studies have shown that if you run during your period, you actually reduce the blood volume. Anyone here a runner notice this? Yeah. Like when you run really hard during your period, you notice that your bleeding is a lot less. Your cramps are a lot better. And you actually can reduce your cycle length by like running really hard during your period. So I would argue try it. The best time to run and do cardiovascular exercise is your follicular phase, so the first 2 weeks after your period when your hormones are kind of going up. The luteal phase after ovulation is probably when you should do your stretching exercises. So like yoga, Pilates, I don't know, ab workouts, Orange Theory, whatever it is you do. Do that during the last 2 weeks before your period, because that's when you get, when you get bloated and then you feel gross and then you feel kind of like, your pants don't fit. Like that's the luteal phase before your period. So then do some stretching and some like movements to kind of help the gas escape. All right. So this is my research. We're already 7 to 5. So I'm just going to kind of go through what I love to talk about, which is menstrual equity. Before I get into that, does anybody have any questions about anything I just talked about? We can also just go off a tangent and talk about anything else. So yeah, go for it. Oh,
And then why does it like form a belly button? Like no other body like.
such a good question. Okay, so the umbilical cord. All right. This is kind of a little bit of a pain. Should I just clip it on? I just feel like I don't want them to like hear weird sounds, but I guess they already are. Okay, so the umbilical cord. So your placenta, right? This is your placenta. This is your uterus. I could pull up a picture too, but this is your uterus. Your placenta stuck right here. Around the placenta is the amniotic sac, right? So like the baby is not just floating in the uterus; it's in an amniotic sac full of water. The placenta stuck here, and there's a bunch of like beautiful tree of life vessels that come into this umbilical cord that goes right to the baby's belly button, right? In this cord, there are 3 vessels. There are 2 umbilical arteries, 1 umbilical vein, all right? Those umbilical arteries feed right into baby's kidneys, and the umbilical vein feeds right into the belly button. In the baby, it's the opposite of the human body. So when the human body veins, arteries take the blood away, veins bring the blood back. It's the opposite in the umbilical cord. So vein takes the blood away, and the arteries bring the blood back. So arteries have the highest amount of oxygen. Veins do not, right? Okay. So when that's the umbilical cord basically brings blood, oxygen, and nutrients to the baby. That's its entire job. When we deliver, we pull the baby out, we clamp the cord. So we clamp it with 2 clamps and we cut in the middle. We usually ask the partner to do that. We're like, hey, you want to do your job? And they're like, okay. And they come and they're like, am I going to hurt it? And that's like, no, bro. There's no nerves. It's very sweet. Like they get so stressed out after their birthing parent has done all this work and is sweating and just like, and then they're like, it's very cute. So they cut, right? This clamp down, and that thing basically like rots and falls off. And when it falls off, and the belly button's actually an outie for quite a while. And then over time, it just involutes into an innie. Sometimes it stays an outie, which is cool, but sometimes it becomes an innie. But that's why it becomes a belly button, because we don't like cut like right at the source. We give it like a few centimeters and then clamp. And then that like little piece, parents, I'm sure you all remember this experience of watching that thing just slowly become black and then fall off. That's why you have a belly button, because it's a wound. And a reminder that you had a parent. Yeah. Yeah. Yeah, so basically if we're worried about baby's oxygenation, if something happened during labor or baby's not crying the way we should, we actually do get blood gases off of the vein and the arteries. And that basically tells us your level of oxygenation when you're born and whether it was too low or not. In life, I don't think there's been much correlation if it's like minutely low. Obviously, this is for people that are like severely hypoxemic during their delivery, babies that are severely hypoxemic. But yeah, we do. And we don't, if that's the case, we don't clamp immediately. We like get the blood off first and then clamp. And usually get it off the placenta, so it's not off the baby. The baby's blood stays to baby. Any other questions? Yeah. Oh yeah, go for it. Right. Actually, a paper just came out looking at long-term effects of hysterectomies, but did not read it. So I don't know the updated info. But what I do know is that based on what we have so far, as long as you keep your ovaries inside, like ovaries are the hormone producers. So the uterus is just the hormone receiver. And so we don't really notice that there's any severe lifetime chronic illness effect if you take out your uterus. There are many ways to do it. Hysterectomies come in 3 different flavors. There's an open hysterectomy, there's a laparoscopic hysterectomy with little incisions, and there's the vaginal hysterectomy where we just take everything out the vagina. You have no incisions on your belly at all. That all is, again, patient dependent on which one you are recommended to get. I would say if you are younger to get a hysterectomy, that is dependent on a few things. So your childbearing decision-making, obviously, right? Number one, if you want kids or not kids. If you're having heavy bleeding and you're thinking this is the only way out, I can't handle this anymore, then we could probably recommend a hysterectomy. We try to do many other things before we get to a hysterectomy in someone who's younger. And by younger, I mean less than 40. Once you get to 40, it's kind of like, all right, now you get the power to really just pick what you want, because now we're like, either way, you'll be fine. But when you're less than 40, we try to like offer other options. But if it's truly a hysterectomy that you want, that's what we'll do. There's been no decrease in lifespan because you get a hysterectomy. There is a decrease in lifespan if you get your ovaries removed. Both of them. You don't want to do that too early. Less than 50 is not recommended. Reduces your lifespan by 15 years. Yeah. Love it. Yeah. Yeah. Ooh, oh, okay. Yes, if you're saying the word abruption, is that what you're thinking? Because that's what it sounds like you're thinking. Yeah. So you're right. In the beginning, formation-wise, that's normal. Breaking and bleeding when you're in the 3rd trimester is not normal. But that would be an abruption. And if that's happened, then that would lead to a decrease, right? Like it's a process, it's all process. It's like a beautiful process. If the blood is coming out of the body, the mom is losing blood, then she's not giving blood to the baby. So the baby is dropping in blood, which means baby's not getting oxygenated, which means then you'll see irregular heart rates on the monitor because that's a sign of poor fetal well-being because they're not getting oxygenated. And just so you know, those tracings, all they can tell you is that baby is getting enough oxygen. You can't tell anything else from those strips. All right, yeah. Yeah. This is so disorganized. That's so fascinating. No, actually, it remembers it beautifully. The moment you pull out that IUD or stop your pills, your body's like, okay, there's a drop, I remember, and returns. It's only in the first few years that it's like, because it's like, remember, there's a lot of like pulsing and like rhythmic beats that happen in your body. So you got to have the GnRH pulsing down, and then enough pulses go down, the FSH turns on, sends signals down, estrogen goes up and says, stop making those sounds, and then it starts an ovulation cycle. So it like requires a little bit of dance before it kicks up. But once you're like middle age, has no problem returning. Except if you take Depo. Depo shots will cause you to have a little bit of an issue with cycle return. Was that your question? I was like, wait, hold up. Everything but Depo shots. Yeah. Totally. So the Depo shot is my least favorite form of contraception because So it works beautifully if you're like bleeding heavily and you just need something because you don't want the IUD, you don't want the Nexplanon. Fine, I'll give you a depot shot. When you're younger, I don't like it because it actually reduces your bone health if you take it for chronic amounts of time, because it truly suppresses, it puts you into almost like a medical menopause, like shuts down your system. So you're not even like cycling even remotely. And so it actually can cause bone loss really young. So if those of us that are like 18 getting depot all the time, probably not the best solution. You want to switch off of that as soon as possible. If you're like 45 getting depot, okay, that's fine. You're like almost in the menopause anyway, so you're probably like, you know, going to transition out beautifully. But if you're younger, I wouldn't. And it has a hard time. If you take it for more than a year, it takes about 6 months for your cycle to come back, 6 to 9 months. And sometimes when it comes back, it's still irregular and it's a little bit like permanently changed. This is not database, this is just observation based. Because whenever I see patients that come back after like a year of depot, they're like, I can't get pregnant. My cycle hasn't come back. Take a little while because it's been so suppressed. And I think it's because it's injected under the skin and it's slow release over time. And because it's just so present and so slow that it's like stronger than just the pill. It's a way lower dose. You take like notice how much you have to take it, right? You take the pill every single day because you lose the level, but the depot is like once in 3 months. So it's strong enough to last 3 months. So it must be pretty intense in general, if I had to think about it. Okay, cool. All right. Menstrual equity. So does anybody know this term? Menstrual equity? Heard of this term? Okay. What is it in your mind? And do you think we have a problem in the United States? Like, where have you heard menstrual equity? Like, I'm sure you've seen the Netflix documentaries. Like, where is it usually talked about? What countries? What continents? Yes. Oh, nice. Yes. So you clearly don't think it's just about the continent of Africa and India, which is great. Yes.
I haven't heard that term. I know about the huge inequity in maternal health and outcomes for Black women.
Yes. Absolutely terrible. I actually, one of my goals would be to actually connect this to that, to make a point that like OB and GYN are the same thing, guys. Like, you got to have good GYN health to get good OB health, and you got to have good GYN health to like ride your life to the end, right? Like, this is all about like our bodies. And so, yes, that is very true and very sad. Yes. Yeah. That's awesome. That's awesome. The fact that they're talking about it and giving you products, that's exactly what we want. I love that. And you just pointed out exactly the point I'm trying to make, which is we have so much data on the rest of the world, on like how it's a missed opportunity for work, how we're like missing opportunities at school, how people that menstruate are not getting access and getting stigmatized abroad. But no one's looking at it in the United States. And we're a country of very diverse folks with varying socioeconomic backgrounds and have the same barriers in health and financial gaps as any other country out there. But no one talks about it here to the level that they should. So, except at your school, clearly, which is great. So menstrual equity, 1 in 5 actually in the United States suffers from menstrual inequities. That's pretty high. Disparities by race persist. And remember, it's not about race, it's about racism. It's about the fallout of racism. It's about historic oppression. So just to be clear about that. It's complicated by socioeconomic statuses that are lower. There's not much research in the United States compared to global research. And apparently, over your lifetime, your products can cost you about $6,000 per person before sales tax. And recently, sales tax has just gone up from 8.3 to 9.8. And I hate to tell y'all, but these tariffs, all of our products come from Canada. It's going to be more expensive than it was. So not helpful, not helpful. 16.9 million people menstruate in the United States, and the that group lives in poverty. So of all the menstruators out there, there's a huge group of people that lack access that they need. So this kind of graph talks about the face of period poverty, like how does it present itself? How does it manifest, right? When those of us don't have pads when you need them, it's like an immediate, I don't know if you've ever been in a situation, you're in the bathroom, you don't have your pad and you're like, ugh. You don't have your tampon, you're like, or cup, whatever yours, and you're like, oh crap. And it's like this really awkward dance of tying your jacket around your waist, or like having to like go come outside. I don't know if you've ever experienced any of that, but it's not easy. And it manifests very differently in different people. And like you said, right, like it leads to missed work outcomes. People have studied it in the United States, mainly in adolescents, and have noticed worsening grades or missed days of school, and those people that don't have access to supplies. So here are some groups that we've looked at in it so far in the United States, people that don't have houses. So there's a study in 2019 that looked at people in St. Louis that did not have a house and basically found that 64% of those people could not afford products. It's actually interesting in the paper, they talked about the poor quality of hospital products. When they would go to the ER to get products, they'd be like, these products are actually terrible. So they'd either go to like period banks or diaper banks to get better products. And they talk about like the wings and no wings and like how people don't understand that it's not just like stick it on your underwear and it works. And if it's like too small, people are like, well, I bleed up here and down here, and like this is not going to cut it. And so they talked a lot about that as well, which I found really interesting. And people found that, 46% couldn't afford both food and products at the same time, which is terrible. Incarceration. We did a study at UNC looking at incarceration and people that are incarcerated and their access to supplies, which is unfortunately like artificially limited. It's not even like limited by circumstance, limited because you're incarcerated. And they found that 53.8% receive less than 5 products at intake, which is hilarious because like 5 products for the entire time you're incarcerated. How is that going to cut it when you have a period every month? And then food and personal favors are common currency, unfortunately. In colleges, in 2021, they did 471 surveys, and they found that actually people in college with period poverty experience increased rates of suicidality and depression. And 14.2% had period poverty experiences in the past year alone in 2021. In high schools, to your point, they found that people actually missed school when they didn't have supplies and access. And I use period poverty and menstrual equity kind of interchangeably. And they found that 79% lacked education on the topic. So like a lot of people don't talk about it in high school. So that's a kudos to your school for talking about it. And in hospitals, we did a study looking at people when they're leaving from the hospital, because we bleed all the time. You bleed when you're young, you bleed after you give birth, you bleed if you have cancer, you bleed if you have abnormal bleeding, and you bleed as you enter menopause. So you're like bleeding a lot at a lot of different points in life. And no one talks about postpartum bleeding. And so we found that people don't discuss products, supplies, and y'all know it's not just the pad, right? It's an ice pack, it's the diaper, it's the postpartum thinks pad. There's a whole system to managing postpartum bleeding, and people don't talk about that at all. So COVID-19 basically did a study looking at income loss and period supplies and found that those who experienced income loss had a higher odds for having difficulties affording products than those who did not, which I think we all think is pretty obvious, but it was more exacerbated during the pandemic. And humiliation, right? Like it's a stigmatizing, humiliating topic. This quote right here is about from somebody who's actually now a menstrual health advocate who was recently incarcerated, and talks about, having to do a strip search when you're on your period and having to take your bloody pad down and then having to put that right back up, or not have anything to put on at all after they're being strip searched to enter and exit the jail. And then at high schools, people kind of feel this like sudden like release of bleeding, but then they have to like cover up and figure out how to get back to their classrooms. And she said the word attempt to cover up the crime your body just committed because you have no menstrual products in sight. And so it's almost like 2 different worlds, 2 different situations, but the same issue. And so it's kind of scary that no one talks about it. Cultural and religious settings. I just shared to you my lived experience as like a immigrant Indian of a Hindu background, but we have pretty strict cultural recommendations around what we can and cannot do during our period. Now, historically, that was probably because that was our day of rest and recovery and space to kind of take care of ourselves. But in today's day and age with supplies and products, it might not totally apply. And so it's kind of this balance between like religious respect, but also autonomy and agency, and kind of the balance between the both, and what's your decision and your choice to kind of pursue when it comes to those stigmas in our culture and our religions. So menstrual health policy, New York City just passed the first menstrual health equity legislation in 2016, requiring public facilities to provide products. Unclear implementation. So they required jails to do it too. Jails are not doing it. So it's like they said to do it, but no one is enforcing it, which is unfortunate, but at least they said it, I guess. 2018 is a First Step Act, but Congress passed it to make prisons actually provide products, but there's no accountability and there's no testing of these measures. And I worked at a prison in the North Carolina State Prison, actually, for providing OBGYN care, and I am 100% sure they do not enforce this topic. So pink tax and tampon tax, to your point, right? It's the sales tax that or value-added tax applied to menstrual products. People can say like, oh, they're harder to make or whatever, but honestly, if we are not taxing medications, why are we taxing products, right? What's the difference there? They should be a necessary item and not a value-based item. And FDA is not required to list ingredients on menstrual products. And why that's important, oh, sorry, this little chart here basically tells us, states that have menstrual equity laws, and they're not many. It's about 13 states currently. So I don't know if you guys know this, but apparently a lot of tampons have recently come out with this, warning that talks about volatile organic compounds or perfumes used in tampons to make them smell better and look and absorb better. There's like chemical congeners, phthalates, toxic metals to improve absorbency. And these, compounds are not actually measured or tested. I will say, as an OBGYN, the quantity of these compounds are so low that I don't think it's enough to impact your blood system and cause long-term effects. But I also know that no study has been done on that, so I don't know how strongly I can make that statement. But as of now, we're not saying that you need to be worried, but we're saying that it's there. So I feel like it's not a clinically impactful outcome, but I think if you buy a product, you should know what's in your product. That's kind of my argument, right? Like, I don't think it's going to cause you cancer. I also don't know that 100%, but for our data now, I don't think it will, but I think you should know that it's there. And people should have choices and information. So menstrual equity by state, it's a very tiny graph right there, but I'll let you know right now, North Carolina is completely negative, has no menstrual equity laws at all. So, right, 5 states do not charge sales tax, 4 states mandate access in public spaces. North Carolina has nothing. All right, so this talks about how OBGYNs don't actually talk about it. That's because we were not taught about it. So we were not taught, therefore we do not talk. And so at this point, one of my goals is to actually introduce menstrual health into like our educational system, into our medical educational foundational phases. It's a work in progress, but I think it's really important because one study noted that only 11% of OBGYNs actually ask people about menstrual needs. Like, do you have products? Everyone uses different products, right? Heavy bleeding can be different based on the product that you use. So it's like, do you know what's heavy for your product? Is it normal for you to fill up a pad every week? Or are you using the wrong product? Should you get a different product that reduces the amount? There's no discussion on the nuance of bleeding. It's just like, oh, you're bleeding. Okay, moving on, right? No one asks the details. And it's a vital sign, so we should be talking about it, and we don't. So, like I said, this talks about the different technologies. There's a lot of new things out there, new apps, new products, new menstrual diva cups, different capacities, underwears, apps. So there's a lot out there now. I think proceed with caution given the current political state and climate. I would not put all my data out there, but I would say there are ways to kind of help you regulate and figure out what your cycles are if that's what you need to do. Okay? So this is if you want to scan and kind of help out by pushing some of these laws through. It's not like we're not trying in North Carolina. Menstrual Equity for All Act by Representative Grace Meng has been introduced a few times, has not passed yet. There's the Period Proud Act to provide funding for social services to remove cost barriers, and the Stamp Act to stop the tampon tax. So if any of these can help out or help push these forward, that would be great. And I can put this slide up at the end of our presentation, so if anybody wants more. But these are my references. But I'm happy to answer any questions y'all have about anything. Thank you so much. Cool. Any questions, or did we? Okay, yeah. Hey. Oh my gosh. Wow. Okay. So I basically went to med school thinking I wanted to do women's health, right? Like I did this whole year traveling, looking at dancing as from women's health, and I danced a lot growing up, mainly Kuchipudi, which is like an Indian classical art, and then I kind of loved the stories of women in those mythological performances, and I was like, I just want to be a women's health doctor and really bring it home. And then I went to medical school, and I was like, I don't know if this OBGYN culture is fit for me, because I think it's a different culture They're a little bit more intense. They're very strong, proud, smart people, but it's not the most friendly. And I thought I was too socially friendly to do it. I was like, I'm not going to cut it. But then I met different doctors that actually were more in line with what I wanted to do. And they talked about menstrual equity, and they talked about, you know, diversity and immigrant upbringing and Black mothers. And they talked about the things that I wanted to talk about. And I thought, okay, maybe I can. So went to residency and then came here to do a research fellowship because the OBGYNs here are amazing, and really just like big thinkers, and the research here that was happening was incredible. So came here to kind of do that. But I don't know, I feel like if I could really have it my way, it would be like a dance clinic with a little bit of OBGYN included. And that's what I really want to do when I become like 50 and I can do what I want finally, you know, power of age. But yeah, thank you for asking. Any other questions? So if you have questions about contraception, all right, y'all, there's a website called bedsider.org, bedsider.org, that goes through every possible contraceptive option out there, every side effect, what the data is, what your options are. So before you go to your next doctor's appointment, please read through that and be like, this is what I want. And then tell them. The other thing that you should know is when you get your IUD placed, you can ask for pain management. I know we're not really great on pain control for our female folk because we're like, I don't know, we're very biased against people that have uteruses. And we're just like, whatever, you'll live. Which is not great because if a man had the same thing, I'm pretty sure they'd be like under anesthesia. So you can definitely get pain control. You can definitely get a variety of different locations to get your stuff done. So it doesn't have to be in the clinic. If you're like, I do not want to feel it, put me out. We can go to the operating room. So like, just remember you have agency in these situations. You do not have to like go with what you're told, and you can push back to ask for more. So like always, and I hope my goal for this talk was really just to be like, I hope you guys know that you can push back, you can ask, you have agency, and you should be able to like advocate for yourself because you should know what's available to you. So I hope if anything out of this talk for the last hour that you've gained, it's that, is that you should be able to ask for what you want. Yeah. Cool, y'all. Thank you.
Really quick before everyone goes, I just wanted to put in a plug-in for our next session. It's going to be on May 13th, I believe. It's going to be focused around blood pressure. And we're bringing in a really great multidisciplinary team. We're going to have a nephrologist, so a kidney doctor, a cardiologist, a heart doctor, and a clinical pharmacist to really talk through kind of the different portions of blood pressure. So hope to see you then. Have a good night, everyone.
Thanks, guys.